Hi everybody, I'm Dr. Roney. Welcome everybody. Hello, happy Tuesday. Sorry we're a little delayed. We're downstairs finishing up with patients, so I apologize. But want to take the opportunity to welcome you. My name's Dr. Roney. We're going to be joined with Dr. Ptak in just a few minutes. So if you're new to the cancer conversation, want to take the opportunity to welcome you. If you've been here before, and I know a lot of you have been, just want to say hi and welcome back, and hope everybody is doing well as we can, right? So what we'll do, Q&A tonight. So we have a lot of good questions. We'll go through, we'll do as many as we can in the time that we have. And then, if you have more, just add them, because we constantly collect them, and we'll be happy to just keep answering them. So this is just overall, I was thinking about this over the weekend. We're doing some studying, and the idea that I like to always talk about is this movement that we're trying to create towards better health, better healthcare systems, right? With all this information that we now have. And day in and day out, we're downstairs seeing patients and just getting feedback consistently that, I was just interviewing a patient just a few minutes ago, going over the 4 pillars that I go over. And, the healthcare provider that they're working with within the conventional model, when they asked, hey, what happened, or what caused this, their cancer, the doctor said, it's just bad luck, and it's kind of like flabbergasted, right? I was flabbergasted by that. And you hear things like that all the time, and it's not necessarily the doctor's fault. I don't blame doctors. I think they do a really, really good job with the information that they have, and I mean that wholeheartedly. You hear me, if you've been on this, you hear me say consistently that with my own eyes, I do believe, and I've seen that most people going through this process are going to need a little bit, when I talk about this kill phase, which I'll go over in a minute, they're going to need a little bit of the heavy hitter, right? They could need chemo and surgery and radiation and immunotherapies and things like that. It's just a necessary evil. We wish that it wasn't like that, but we often have to utilize that within their protocol in order to get them well, right? But the missing link, if you will, which a lot of you know that if you've watched, is that it's one chapter of a 10-chapter book. And that's the I guess alarming part in today's world, where information is everywhere now. So the doctors, even though that they're educated within that system and they're using the tools in their toolbox, and I definitely don't blame them for that, because I think they're doing the best job that they possibly can, it's really the system. And I think that's when we do these cancer conversations, it's the system that we're trying to change based on information and education. And if you all have more of this information and education, and you're taking it to the standard or conventional model, and you're asking these questions and they don't have answers, more and more people are going to want to do this type of care as they learn more and more about it, which we're hoping, starts to change the game a little bit, right? So the point I'm making is, when we do these cancer conversations, the reason and the passion behind it and the goal behind it is to just push this movement forward by educating, right? And so you've heard me say it if you've been on here before, I personally just want to thank you for being here. I know a lot of you see me in the clinic, and we talk about the cancer conversation, and you're happy that it's being done, and you're happy that you have, a resource to go to every couple weeks to learn more and more. So just want to say, appreciate the feedback, appreciate you being here, appreciate you learning, appreciate you being part of the movement. It's the only way that it's going to move forward. So I definitely appreciate it. We all do. So having said that, you want to come in, Doc?
Sure.
Yeah. Earlier about it might be a little delayed getting here. So all is good. So I was just telling them a little bit about the movement, right? Mm-hmm. So I was telling the story of our one of the patients that when she asked the doctor, what caused this, they said, well, it's just bad luck, mm-hmm. right? That's a recent one, and you saw this patient I think yesterday. But anyway, that that mentality in today's world, we were just going through, and more education and more knowledge, right, is going to help just further the movement. That's all. It's not good or bad or indifferent. It's just the system, and right now that's the way the system is. But I think we can make some headway over time. So, let me, if we all don't mind, give me like maybe a couple minutes. We'll go through the 4 pillars, because a lot of the questions that do come in can be related back to at least 1, 2, or all of the 4 pillars. So I just want to give you a brief overview as quick as I can. I think I've got this. I could. I'm a talker, so, but I'm going to try my best. All right, so pillar 1 is going to be the testing. So the way I look at the testing is there's 2 parts to the testing. It's the cancer part, looking at circulating tumor cells. Now we have all these new labs that have come out, DATAR being one of them. And the Guardant's been around, but Guardant, we have RGCC, we have Fulgent, we have, what are some of the others?
Well, there's some that are even cancer specific, like HPV-driven cancers we can test with NavDX, and so...
Prostate specific, right, too?
ExoDX, and so there's different cancer specific type ones, too, to measure tumor burden or activity, but also ways we can think about individualizing your treatment, making it more effective.
And that's the information that's almost like it's at a rapid pace. It's coming out almost daily, right? Monthly, yearly. So it's a good thing. So these labs that we now have access to that we're utilizing for testing can help identify with more specificity. Is that fair? So we want to do that. We want to get those circulating tumor cells. We want to use the tumor markers. We want to use, now the QT imaging as an example when we're talking about imaging and testing. That's a breast exam. Basically underwater ultrasound, right? Resolution's very, very high. So these tools are coming out, is what I'm saying, right? So we're utilizing more and more of these tools, not only from a standpoint of what we need to know right now, but also the surveillance part of it.
Well, it's funny you mentioned that too, because usually when a patient starts here, we're visiting very frequently initially, and then when everything goes right and we slow you down to every 3 or every 6 months, like long term.
Yep.
I do follow-ups with some of those people, and they come in and it's like, well, now are we going to retest that thing we used to test? And I say yes. And since we last saw you, we have 6 new things to consider, or I have a new way of looking at that past result that we didn't really know how to work with. So there's always things to follow up on.
More stuff, more data points. So the testing is a big part of it, right? And there's more data points that we look at. We talk about nagalase and PHI and D-dimers, of course, the tumor markers, the circulating tumor cells, and then the scans that you could do too. So if we put all those together, we can create a very comprehensive view of where things are, right? So the testing is a big part of that.
Well, that's for cancer. And then the second part.
The second part are the causes. So we get into in-house, we could do energy type of testing, which is I think very sensitive, and it can pick up things early in the process as far as dysfunction in the body. And then we also can do your blood, urine, and saliva type of testing, and then the scans too. But in general, your energy type of testing and your blood, urine, and saliva, we can start looking at a lot of the pathogens, whether it's bacteria, viral loads. We could look at your parasite load. We can look at your fungal load, like mycotoxins and candida. We can look at heavy metals, non-metal toxins, but which is what they consider antigens or foreign invaders that get into the body, into the tissues, into the cells, and then can create this inflammatory response, which then starts to create a lot of damage to the cell, keeping it simple, right? And then you get into the metabolic part. Well, what is their stress level? What are the stress levels? What is going on with their hormones and their cortisol? What's going on with their blood sugar, their iron levels, right? You get into thyroid function, you get into et cetera. So the list of causes does get long, but we have a checklist. And we just work through the checklist and make sure that we're finding things, because you can't fix what you don't find. And then when we find them, we're putting protocols together in a priority list, not all at once, to take step-by-step action to start removing some of those, I call it fuels to the fire. So as long as we get, the body, a lot of the junk out of there and regulate your systems, create homeostasis, right? That's going to be a big factor. One of the pillars that we talk about is also the hallmarks of cancer. You get a weakened immune system, you get low oxygen, high acidity, low voltage of the cell. Inside the cell, the nutrition levels start to decrease, which hurts the mitochondria and the communication of the cell. So as long as we're looking at those as well and making sure we're cleaning up the cell and then taking away why the cell became damaged or has become damaged, we're doing a pretty good job, right? The big pillar, which is pillar 2, which I kind of skipped over, is starving and killing the cancer. That's a biggie. So whether it's pressing on the glucose, ketogenic diet, pressing on the glutamine, right? Or using repurposed drugs to try to conceptually block some of the pathways that feed the cancer cell, we're at least starving or doing something to lower the amount of fuel that the cancer cell gets, right? Conceptually. And then the second part is that kill phase, which is chemo, surgery, radiation, low-dose chemo, immunotherapies, or it could be high-dose vitamin C or hyperthermia or some of these other natural, more natural modalities or interventions. The caveat, which I always tell patients, is are the natural things enough to do the job that it needs to be done? And that all comes from the testing and the scans and everything else. So sometimes, I kind of liken it to we're painting a picture, and the picture you paint and you go, oh, or sometimes you go, ooh, right? And so sometimes these natural approaches, although look great on paper, I consider them maybe a cannonball or a grenade, but then your heavy duty hitters, the conventional stuff, even the low dose chemo, might be a bomb or an atomic bomb. And based on your history and your diagnosis and what's going on with all the data points, some people may need that. Unfortunately, I think a lot of people might need that.
Well, we have to think of it too, like one of the hallmarks of cancer is that it's growing and dividing at a very rapid pace and consuming a lot of sugar and nutrients. And if it's confined in one little spot, it's not a huge threat to your health, depending on where it is in the body. But if it's already causing compromise in a specific organ, a vital organ, or it's disseminated and there's multiple spots, then we need something stronger, because natural things do have a lot of efficacy, but they can work very slowly, and it sometimes takes a long time to crack a code that leads to tumor shrinkage. And if we're at a race, sometimes
it's a great way to put it. And sometimes with something that's going fast, you need something aggressive to slow it down. Is that fair? I always talk about this tipping point. I can't really totally explain it, but I go, sometimes if this is the tipping point and you're below this, you can probably get away with using, some of these natural remedies and layering it. But a lot of people, it's beyond that tipping point, to your point. And so we have to do things a little more aggressively. It's a necessary evil, but what I will tell you is what I've seen here over the years, if that has to be something that is used, then doing all these other chapters of the book make it much, 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 much better. And we see that downstairs all the time. The eyeball test, I tell everybody, the eyeball test doesn't lie. You watch people do these things and their upside is just significantly better and their downside is significantly lower, or not as low, right? Yeah. It's minimized. So the floor and the ceiling stay much, much more together. So the testing, the starve, the kill, the cellular health, and looking at all that and getting rid of the causes, that's the plan. So that plan.
Did you say immune system?
What's that? Yep. Okay. Yep. So part of pillar 3 is a weakened immune system. So we want to stimulate that immune system aggressively, right? Literally right out of the gate. So with utilizing all of that, now there's a lot of details to that I left out, but that's the plan. That's what's going to help people the most beyond, if you think about chemo, surgery, radiation, things like that, it's just one aspect of that 4-pillar plan. And for most, like I said, it's a necessary aspect because of how Dr. Ptak explained it. But you have all these other chapters to be able to support the body and to create health. Yes. So that's those are the 4 pillars. So some of these questions will revert back to the 4 pillars, and I think it'll have a much better understanding. So, okay, so let's go. Let me pull up the slide presentation.
So I'm a naturopathic doctor licensed in California. I went to a 4-year naturopathic medical program in San Diego at Bastyr University, and before that I studied at molecular biology at Princeton University. I've been here over 3 years now.
Mm-hmm. Yeah, you were here for a while shadowing and kind of helping out, and then became a full-time provider. Mm-hmm. So, yep, good. Yeah, great background, smart, and very conscious is what I'll call it, right? You're conscientious about doing a really good job. So that's what you want with a doctor, for sure. So, okay, so Cancer Center for Healing, a lot of you know if you've been on where we're located, Irvine, California. I mean, close to the beaches, really good area for a lot to do. Not that that's like, it just is. It's just reality, right? Mm-hmm. So here it talks about on this slide, the Cancer Center for Healing, the types and stages that we work with, and then the collaboration as well. So I think one of the things that I think is really good, the testing we talked about, I think is really, really good. And the surveillance is very, very good as well. Excellent even. And then also the affiliations over the years that we've developed. We were just at, I want to talk about Dr. Pinzone and the hyperthermia. So hyperthermia is a very good adjunct modality or therapy intervention to be able to help heat the tissues or the tumor to a very high degree, maybe somewhere in the 106 to 109 range. And what it does, it actually opens up the cells or the blood supply so that chemo or radiation actually works better, right? Mm-hmm. But it also has a cytotoxic effect on the cancer cells. Mm-hmm. So if that's used in conjunction with some of these other things, it tends to work really well, right? And it's insurance covers it, which
depending
is great.
On the insurance.
Depending on the insurance, exactly. But it can cover it. Let's put it that way. But so that's a great one. And then intertumoral, therapies and things like that. The point I'll make is we've been able to develop some affiliations that I think sometimes we're not the only answer. It could be multiple answers and multiple layers to be able to help. I feel good about that part too. Mm-hmm. So I always like to mention it. Okay, so let's get into the personalized prevention plan. I'll talk about that at the end. I think this is like vitally important, but let's get right into the slideshow here. So virtual patients, do you need to live in California to be a patient?
So initially, especially, yes. It's really important that we're able to do physical exams to really understand your history. A lot of the data we need to collect has to be collected in office here. And that just ensures that we're able to deliver the best kind of medicine. Like if you have a wound related to a tumor and we can't do anything to see it or help it, that's a limitation.
Yeah.
So it's really important that you have a tribe locally if you're going to be returning home. But as far as continued care, a lot of patients come out here to get all of this data collected, and then we help set up a plan for when you return to home if you're going to do conventional treatment there, or there are some ways we can monitor you from afar. It's a very case by case basis as far as how often we'd recommend you come out.
Right. But initially
have
to be in person.
Has to be in person, and then usually it seems like we're recommending another in-person follow-up like 3 months later, mm-hmm. depending on what's going on, is a typical thing.
Yeah.
And then following that, like every 6 months, at a minimum, we want to see you every year.
Mm-hmm.
And then on a case-by-case basis, that might need to be more frequent. But
yeah, exactly. So if you think of if somebody has cancer, mm-hmm. right, what would, not necessarily standard of care, but what makes the most sense to be able to give you the best care? Mm-hmm. That's really what it comes down to. So evaluating somebody in person is definitely step one. And then from there, if you have your oncologist and your team at home and you're being monitored that way very frequently, the things that we're doing are helping in conjunction. Then we can work out what that looks like throughout the year. But yeah, to your point, it's individual. But in the beginning, gang, it's definitely something we need to see you in person for sure, just based on optimal care. Hopefully that helped. Okay, so low dose naltrexone for stage 4 thyroid cancer, which is probably metastasized to the lung and is invading the esophagus. What is the dosage? Is there anyone in the U.S. who specializes in this treatment? Any resources regarding this treatment you would recommend? Dr. Ptak, we're having a little bit of a discussion about this earlier, and I'll jump in just briefly because this is what I mentioned to her. This is a good, I'll use the term ancillary treatment, but I wouldn't call it a primary treatment personally. I think something like this can be used in conjunction with other types of care within the 4 pillars. That could be, if somebody is doing chemo or doing radiation or doing, some of the more conventional type of treatments, and they're starving and they're starving the cancer. They're using vitamin C. They're using different layers. To me, this is just another layer. How would you?
Yes. Yeah. So, low-dose naltrexone or naltrexone is one of hundreds of different repurposed drugs that could be layered in to put pressure on the cancer cell, either starving it or increasing the effectiveness of other treatments or having some cancer cell killing effects on its own. Not like an atomic bomb, but, like a little sparkler.
Yeah.
And for those that don't know, naltrexone is a repurposed drug, is a medication that's typically used conventionally for other indications that has also been shown over the decades to have some anti-cancer effects. So it's used in cancer care for anti-cancer effects. But naltrexone at full doses works to block opioid receptors. So it's actually used in addiction medicine. That's at high milligram doses. Low dose naltrexone is usually between 1 and 4.5, or you can go higher, but in that milligram range. And then some people do better with a lower milligram dose. And the dosing is very individualized. It's not like there's a magic number. The most common is about 4.5 milligrams, but more isn't necessarily better. Some people tolerate 3 milligrams. Some people tolerate 0.5 milligram. It usually depends on other aspects of your history. When low dose, LDN is used a lot in integrative medicine as an inflammation and immune system modulator. So I use it a lot in mold and Lyme disease and autoimmune, because it takes an overzealous immune system over here and a weakened immune system over here. Sorry, my hand's not on the screen. Yeah. And brings them back more to the middle area. So when it comes to choosing repurposed drugs, I'm often looking at, okay, what are our goals from a cancer perspective? And then what comorbidities does this person have that I can help with a repurposed drug?
So kill 2-3 birds with one stone.
Yeah.
Maybe. Yeah. Agree.
And let's see what else. So as far as the low-dose naltrexone goes, in the context of cancer, I often think of it as something that helps increase the efficacy of chemotherapy. It seems to have chemotherapy sensitizing effects. So when it's in the body and you're receiving chemotherapy, the cancer cell is more susceptible. Of course, we're always paying attention to, is this repurposed drug going to interact with the chemo? So again, it's a case-by-case basis, and what chemotherapies are you getting? But that's one of my go-tos there, especially if someone has a history with autoimmune, mold, Lyme, etc. So for thyroid cancer, typically you start considering chemotherapies when it's at a stage 4. Lower stage, it's not a go-to, but if it's in the background of like a Hashimoto's or Graves', that's where my mind goes. Yep. Maybe the low-dose naltrexone. It's stage 4 for thyroid. They start, talking about
more aggressive care.
Yeah, more aggressive care, targeted therapies, targeted drugs, chemo, spot treating with radiation. But in the context, when you mentioned Dr. Pinzone, I thought of this question because they seem to have a lot of efficacy for head and neck cancers, and this isn't quite like squamous cell of the throat, but considering the thyroid and the esophagus has the location.
Yeah, it's easily accessible. So yeah, that's a great explanation. But yeah, it can be, it's very good, and it can be used appropriately in the right context, if you will, with other modalities. Fair?
But as far as resources goes, there's a lot on PubMed.
Yeah, there are. I agree.
Okay.
All right, vitamin D levels high. I stopped taking any supplements that contain vitamin D and it's still staying high. I do use red light. Would that cause this? And are there dangers of too high levels of vitamin D? You're at 98.7.
Okay, so vitamin D, it's not red light. So red light is in the visible light spectrum and it doesn't increase vitamin D levels. It's really UV that helps with vitamin D and raising it. So sun exposure. So it wouldn't be the red light. I'd be curious about...
And then how long you stopped
How long ago you stopped the vitamin D. It's a fat-soluble vitamin, and so it does stay in the system longer than your B vitamins and vitamin C. So curious about that. And I wonder how high it got, before.
That's not too bad, right?
Yeah.
Like in the literature, even in the functional med, world, 60 to 90, even 100, you're not too worried. During COVID, they even upped that. Some of the functional med doctors that I followed were looking at 110, 120. Now, again, it can be toxic at some levels, but I wouldn't worry too much about it at 98. I don't know what
as far as it showing up as being too much, you'll usually see it in the calcium levels on a metabolic panel. Vitamin D is one of the things that's used to help calcium get directed into bone, but if the level gets too high, it starts pulling it out.
Yeah.
And so you start getting hypercalcemia or high calcium levels in the blood. And that has a host of potential issues, but it's when you get the vitamin D level down to normal, the risk goes away.
Yeah.
As far as, naturally high levels of vitamin D, that's something that I haven't seen before. I was poking around a little bit in some medical journals, and I saw potentially a connection to like inflammatory bowel disease. I think I saw something with granulomatosis of sorts. So there are some rare conditions that might lead to endogenously high levels, but it's very rare. And so I think we would need more context to say, how much were you taking before? Right. How high did it get? How long has it been?
So I'd say rough estimate 15, 20 years in functional med. I've never seen it naturally high. And that's probably thousands and thousands and thousands of labs. So if it is, it's a rarity, right? Like you said. So yeah. Okay. All right. High dose vitamin C as a preventative. If so, how much and how often? So
I don't typically go to this as just a preventative. What vitamin C is doing to kill cancer cells is increasing hydrogen peroxide. It's one of the mechanisms around and in the cancer cell, which cancer cells, as much as we think of them as being like so hard to treat, it's true. They're actually quite unstable as individual cells. And so vitamin C at high doses, with the hydrogen peroxide and oxidative reaction you can get, is enough to destabilize and kill them. And so in theory, doing some when there's no detectable cancer, but little pre-cancer cells that everyone has some amount of, possibly could help with that. But I think more of your immune system is able to do that on its own. So I'm a lot more interested in, from a preventative perspective, in measuring and optimizing your immune system and eliminating all those root causes and obstacles that Dr. Roney was highlighting in the beginning.
Yeah, and having said that, so some of those fuels to the fire will dysregulate your immune system and actually weaken it. So it's like somebody fighting, say we were fighting 10 people at once. That's an exaggeration, but it's going to dilute what we can do, to protect ourselves. So the immune system can get overwhelmed. Epstein-Barr's and the viral loads and the bacterial loads, the chronicity of those can definitely overwhelm it. And so to your point, getting rid of those and cleaning all that up is going to naturally allow your immune system to work better. And then even, say you did Myers cocktails, right, where it's a lower dose vitamin C, maybe 15 grams or so, where you're getting some other things within that vitamin C. I don't know that it's a bad idea, and that's the conversation I wanted to bring this up for, to see what you thought, as far as just, hey, keeping my immune system strong on some type of, maintenance level. Not a bad idea, right?
Yeah, the 15 grams isn't going to be high enough to achieve that cytotoxic effect for most people. But vitamin C has many other mechanisms, from activating your T lymphocytes or T cells. There's some evidence that it helps balance the microbiome in a way that favors a better immune system. So that's important. I had an interesting case. I just followed up with her last week, and she, as far as the immune system and root causes goes, it's kind of interesting. She's had low white blood cells since the 90s, and no one could ever figure it out. And we've been systematically checking off her, root cause things, and she just had her root canals addressed. And when they took out the root canal, her next blood count showed normal white blood cells for the first time since the 90s.
Wow.
And so when it comes to a integrative plan, the number one step is always remove obstacles.
Yeah.
Because we could throw 1,000 supplements at something, but if the obstacles are still there, you're not...
i.e. causes, right?
Causes.
That's a great...
You're fighting an uphill battle. So vitamin C might be helpful, but I'd rather focus on the roots.
Agree. All right. My recent mammogram was clear, but I have dense cystic breast. I had a breast thermography which showed likely estrogen dominance and a hormonal imbalance, and a small spot on my left breast of inflammation. What do I do next?
So there's a couple points here to talk about. One, I'd be curious about the type of mammogram, because a regular screening mammogram can't usually see past dense tissue. So I always like to follow that up with an ultrasound. And QT is kind of an interesting, new type of ultrasound technology that we're investigating and evaluating and collecting data on. So, what kind of mammogram? Dense breasts tend to have overlapping, roots of the estrogen dominance. So addressing the hormones should help with the density.
And usually we see
and the cysts.
Maybe fibroids, endometriosis, things like that usually coexist with
painful, heavy periods. There's other aspects of the history I'd be curious about. Sometimes we see cysts related to low iodine, so there's a nutrient component too, the micronutrients and minerals. I think, next I'd be considering hormone testing to really get a baseline and, assessing what the symptoms are. So sometimes patients that are having a lot of symptoms, I make a list of the symptoms and I say, how severe is this? How severe is this? How severe is this? So that when you follow up, you can have an objective measurement of improvement and know how to modify the plan. But I also think of thermogram in the context of vascularity, and estrogen dominance can contribute to that, or a deficiency in progesterone, rather. But I also think about...
Which is a big stress component, potentially, but go ahead, sorry.
That's okay. So grounding is something that can reduce inflammation in an area. So I'm thinking about voltage overall. There's a lot of variables.
Yeah, I mean, essentially, if you look at this like pragmatically from a plan standpoint, more imaging that would be helpful. So like QT imaging, if it's available, that would be something that I think would be
just a regular ultrasound.
Ultrasound, QT imaging, something that gives us maybe a little better, clearer picture. You can, and then you go into the cause part of it, where you start looking at, well, what are some of the top priorities that you would look at from a cause standpoint? Hormone imbalance and cortisol, that connection, like a Dutch test or something like that, might be super relevant in a case like this to see. I mean, there's others, but we definitely want to make sure that spot is identified and addressed properly, and then start looking at some of the causes. And again, history, like Dr. Ptak was saying, a history guides you really, really well as far as where to start prioritizing. And then there's all these additional tests now that we have. If we are worried about that spot, you can do some of the liquid biopsy testing. You could do the tumor markers. You could do, right? We could this could be probably easily, I don't want to say easily handled, but to Dr. Ptak's point, there's like, okay, we're going to do this as far as testing, then we're going to do this as far as causes, then we're going to do this, kind of look at everything and create a portrait, if you will, on a blank canvas, and go, all right, this is what we have, this is what we need to do. And sometimes the testing then opens the door to other testing. Mm-hmm. You know, so just, but that's kind of the gist of it. Mm-hmm. Would you agree? Fair?
Yes.
Yeah.
Ready?
Yes, ma'am. My dad has prostate cancer, is intent on doing radiation. What are good alternative options? How can I begin conversations that will help him see alternative treatment options in a positive light? Good question.
Yeah, well, there's a lot of context that would be important for this kind of question. Mm-hmm. Is this an early stage cancer localized in the prostate, and they're considering like I don't like using the word curative, but are they intending this as like the main treatment?
Right.
Or is the prostate cancer disseminated and spread like to the spine, in which case radiation is sometimes used for palliation or treating like a fracture related to metastasis. Mm-hmm. So that's important context. If we're talking about the first case, surgery and radiation are the most common go-to treatments. There's consideration from an integrative, not just integrative, it's a conventional treatment, but I mean as far as outside of the box goes, treatments like HIFU, high intensity frequency ultrasound that has like a heat ablation of cancer cells, cryoablation, depending on if there's a discrete nodule. With every treatment, there's benefits and risks, upsides and downsides. And so I try to have a conversation with every patient about what is your oncologist or urologist in this case recommending, what are the upsides, what are the downsides, how does your personal history influence what those upsides and downsides are, and then what are the alternatives. With radiation, sometimes we get damage to neighboring structures like the urethra, the bladder. Usually they can protect the colon with some new technologies, but you know, that's a consideration too.
The dental nerve, you know, all those different structures the nerves, down there.
The blood vessels. And the research helps us tease out what the data shows as far as how likely that kind of risk would be. And then as far as, you know, palliative to a spinal lesion, for example, we don't have anything strong enough as an alternative. Right. Usually there's less downside to that kind of treatment because they only do it for a day or 5 days because they're just trying to minimize activity in that one spot versus really treat and kill and remove. But that would be important context. And then I think I covered some alternative options. We talked about Dr. Pinzone and how the hyperthermia. So I guess to clarify, hyperthermia is technically a type of radiation.
Yeah, true.
It's just not ionizing, which means inducing DNA damage. And so it has like a cumulative or additive benefit with the conventional radiation. There are some hyperthermia machines on the market. The tricky part is the machine getting the tissue hot enough? And so if we're talking, you know, a medical grade hyperthermia, we're talking about reliably getting the tissue to 106 to 109 degrees Fahrenheit. And that, as far as that being like a primary or adjunctive treatment goes, some of those other machines might be helpful, like in the context of a high dose vitamin C option, but not as like a primary treatment. Just to touch on that. Yeah,
I agree. Yeah, I think to your point, the context, right? So doing radiation, but what was the diagnosis? What are the specifics of the diagnosis? That definitely helps. We do see this in this prostate world, prostate cancer world, where goals become a big important factor. Yeah. Some men's goal is, look, I don't want to go do anything aggressive if the numbers allow me to do this, right? And because they don't want the damage. So their goal is, I want to just keep this at bay. Right? And that's a strategy. And the strategy then is, well, we're going to do all these different alternative hyperthermias, vitamin C's, et cetera, to be able to just keep it at bay, because their goal is not to do anything damaging. And then others' goal is, look, I don't want to live with this. I want to be done with it. Then that's where radiation and surgery and even proton therapy, which is a more like specific radiation, can be used to be able to do it. So it's then figuring out, okay, what's the person's goal, and then strategizing from a plan standpoint to be able to, like this, if say your dad definitely is set on radiation because that's part of his goal, then we want to minimize the downside. That becomes our goal to help meet him in the middle there. And then it's a matter of, okay, what else can we do to not only mitigate the downside, but what are other things that we could do either treatment-wise or to strengthen the body, clean up the body, get rid of some of the causes, etc.
Make the radiation more effective.
Yeah, exactly. Exactly. So it's there's a lot of variables in this one, but I hope that helped, because I think you nailed it. I think you gave her him or her a ton. Okay. All right. So cheapest and simplest things to do for supplements to take for pancreatic cancer if I do not have money to pay for functional doctors. So that would revolve around the blood sugar and insulin and such, right?
Yeah, so my first thought went to diet with this one. There's some research, and again, you want to, be directed by a doctor, but ketogenic diet's been shown to sensitize pancreatic cancer cells to chemotherapy. And then also when you're in more of a keto diet, you're taking a burden off the pancreas from having to produce an insulin response. You're decreasing the stimulation of the pancreas in general.
Yeah, you're making it work less.
Okay, so let's see what else. Supplement wise, it's a little tricky. It kind of comes down to the goals. There's generally anti-cancer supplements, which there are thousands of them. So I don't know that there's a specific one that I typically go to for pancreatic.
Would we use, your things like berberine? There's
turkey tail,
berberine, burdock root, things to help the AMPK pathway.
I'm also thinking about sometimes if the pancreas is obstructed related to a pancreatic lesion, we need to support the liver and gallbladder, because the bile duct drains, it goes through the head of the pancreas and out, and so sometimes you have to replace gallbladder function. Sometimes they prescribe medication to replace this, but I can't tell you how many people I've talked to that weren't ever prescribed these drugs.
Bile salts, right?
Yeah, bile salts, and so supplementing with bile salts takes a burden off that system. Yeah.
So your glucose probably regulating supplements would be really good. Keeping your ketogenic diet intact, doing that to slow down the glucose and the insulin production, and then working on your gallbladder and your liver.
The basics, vitamin C, vitamin D.
Yep. Yeah, I think that's a pretty good start. A small rough patch on my face near my upper lip. Dermatologist saw it and just wanted to use nitrogen to burn off the cells, but I was concerned about scarring. She said it's likely squamous cell cancer. I've been trying to use essential oils. There are no other symptoms, though I need to burn it off. Concerned, I'm thinking it's my face, so maybe I need plastic surgeon to do this also. Do I need to confirm if it's cancer or not? Usually they'll scrape it at least, and then pathologically identify, right? Do they do that?
It kind of depends on how suspicious the lesion is. If it's like borderline, then they usually just nitrogen burn it, but that doesn't typically lead to significant scarring. So I wouldn't be too shy about that, depending on where it is. It says near the upper lip. The lip can be quite sensitive, but generally does pretty well.
How about our endo laser?
Yeah. Basically, the reason why you want to do something about it is that squamous cell cancer of the skin has the potential to invade and spread to lymph and other organs. And so in case it is, you don't want to do nothing. The nitrogen, I think, is a reasonable consideration. Dr. Roney just mentioned the endo laser, and what he's mentioning is a a protocol or process called photodynamic therapy, where you combine a photoreceptive substance or a substance that absorbs light very strongly, applied to a lesion. You give it time to absorb, and then a couple hours later you actually direct light or lasers at the area, and it activates the cream or substance or whatever is being used in a way that causes inflammation that kills abnormal tissue. So it's typically used in like a actinic keratosis, like a precancer type of condition, and then sometimes in like an early squamous cell type of condition, as long as it doesn't appear to have already invaded or spread. The most common substance in light are 5-ALA or 5-aminolevulinic acid, combined with blue and red and sometimes UV, a safe UV light color to activate it. Yeah,
and we've seen that work well.
Yes.
And
without scarring.
Without scarring, yeah. So that's an option as well. But yeah, I mean, the nitro typically should be okay if you're talking about upper lip. I don't think it would scar too much. I've had some of those done, and it typically heals real well. Face heals well. It's one of those areas that heals pretty well. So hopefully that helped. Can a tumor be surgically removed and not spread the cancer?
Yes. Yeah, so some considerations for that, and it kind of goes to another question we often get about like biopsies and seeding risk. Yeah. The concern is that with, I call it poking the bear, you're kind of making it angry, and could make it the inflammation and increase in signals for increased vascularity to the area that can kind of accelerate cancer processes. With biopsy specifically, there's concern that as the needle punctures the tumor and is withdrawn, it can leave a trail of cells behind it. There's some technologies like vacuum assistance that reduces the trail of cells in the wake of a biopsy. But I was actually researching this recently, and there's research done on how many cancer cells are found in the tissue where a tumor is biopsied, like how many cells are really seeded in that case. And the research shows that they're there, but that the number of those cells was reduced when the time between biopsy and surgery was longer. And it wasn't that tumors formed there, it was that those cells that get spread are, if that even happens, are not typically viable cells. So it's not that any cancer cell can just break off and exist. They're actually quite fragile cells. There are certain cells that are more cancer stem cells that have more mesenchymal activity and more longevity. They live longer. Those are the risk, but there's no guarantee that those are even part of the biopsy process. Some people that have a suspicious lesion are recommended or opt for just surgically removing it as opposed to biopsying it. And in those cases, any of that risk is greatly minimized, the whole seeding thing. And the idea is that the surgeon, if they can, they get a wide margin. So if this is the spot, sorry, people on the computer, you're cutting around with a wide enough margin that you're not actually poking the bear. And then you're doing things integratively to optimize benefit and minimize downside. Hyperbaric reduces surgical complications. Vitamin C, modified citrus pectin, a lot of nutrients used have been shown to reduce the risk of spread related to a surgical procedure.
That pre and post, so to help pre and post protocol, I should say, to help. But yes, this is definitely can be, and I think it's important when you learn a little bit about the integrative model, you go, okay, if this happens, how do we mitigate the downside if we need to do this? So there's things that can be done pre, during, post, maybe not during, but post for sure, and then moving forward, the things that we could do, like Dr. Ptak said, to reduce that downside significantly. Anything's always possible, but my thought is if you put a plan together that's pretty tight and well researched, and the details are done well, you just minimize it significantly. That's the way my brain works that way, where I like more predictability and less chance. So yes, it can be done with a lot of the things that Dr. Ptak said, for sure.
But kind of an undertone to this question overall is basically, is all surgery spreading cancer?
Sure.
And
right.
the answer to that is no.
Yeah. Yeah, based on, like you said, right? You're not poking the bear. You're going way around it. So it's good. Does ivermectin or other anti-parasitic drugs take a toll on gut health? Good question.
I haven't seen any clinically. I haven't seen ivermectin increasing GI disturbance, although some people it can impact liver function. So maybe indirectly we're thinking gut health from that. I was trying to research it a little bit earlier today, and there was some interesting data actually on it improving various aspects of the microbiome. So I'm curious to research that a little bit more. I'm not as careful with, or you don't need to be as careful with ivermectin, but when you start getting into the things that have crossover antibacterial type effects like metronidazole or flagyl, which is antiparasitic, that's also really strongly affecting your microbiome, and yes, would impact gut health for some people in a good way if you've got bacterial overgrowth, but for others in a way that disrupts the microbiome. So it is drug dependent. That's the main thing. Yeah,
and then just supporting the gut. I think it's important to understand, say, ivermectin as an antiparasitic. It definitely has that ability, and actually, if you're removing some infections in the gut, that should help your gut function overall, or could, right? Because when we look at the gut overall, one of the R's that I use, a 5R approach to gut health, removing infections is a big one. So if we can reduce that load, that parasitic load, the gut, less inflammation, should actually, or could get actually better. But then supporting, like Dr. Ptak said, the microbiome and making sure we have good enzymes and we're putting good food in there, all that matters as well. So it's again, there's a plan to it that I think would, if there is a little bit of gut health toll, that it could be totally offset. I think ivermectin's pretty innocuous.
Yeah, my experience with ivermectin and the albendazole or mebendazole categories, praziquantel, I haven't seen much negative impact.
I agree. Myself as well. All right, stage 3. Is stage 3 stomach cancer curable? What about if 3/4 of the stomach has been removed? I would not like to go under the knife again. Please help. Yep, this probably goes back to the whole 4-pillar kind of approach. It's hard to say, I think, and you would probably agree, like curable, I don't get into that word much, but what I like to do is, okay, how can we, with something like this, what is the plan to create the best upside? That's, to me, that's a more, I think, a better question or answer is to go through that part, which would be, okay, and I'll let you definitely chime in on this, but we've got to get the whole food thing right and make sure you're getting the right nutrients and how we can do that, and make sure we're working with that gut health. And then, of course, making sure that we're also doing as much as we can with the terrain and as much as we can with cleaning up, the causes and doing all these things that I think makes the body healthier would be my approach in this case, right? What's your thought?
Yeah, and then stomach cancer is tricky. I'm curious about what makes it stage 3 and where it is. Because surgery is usually used if there's a possibility of removing everything, or if you need to debulk tumor to save and preserve your healthy tissue function. Typically, we're also thinking chemotherapy with or without immunotherapy for stomach cancer as well. And so it really depends on a constellation, a tribe of people supporting in the ways that their expertise allow.
Yeah, right.
So I'd also be thinking the hyperthermia, is immunotherapy recommended? How can we support and optimize the immunotherapy effect? Stomach cancer, it's tricky as far as getting it to respond well to chemotherapy, and so I do think it takes a good multifaceted approach.
It's a layered approach. Mm-hmm. When you get it, the stomachs, the pancreas, some of these other cancers, you want to hit it from as many angles and as many layers as possible. But we've definitely seen that work well, and Dr. Ptak mentioned it, whether it is hyperthermia, whether it is the chemos, whether it is, some of these alternative modalities, that stacked is what I think gives the best chance.
But as far as surgery goes, my question is, can they get all of it? Mm-hmm. Or is it possible that you need a therapy to reduce the tumor burden to then be able to get all of it?
Mm-hmm. Good point.
And then when it's gone, how do we be really aggressive with all the supportive integrative care? Sometimes they continue chemo and immunotherapy beyond when you get rid of everything to treat undetectable disease that's there. But that's where the integrative stuff can also really be a big help.
Yeah, to that point, I mentioned this, a couple times on the conversation. We'll have patients that are clean, but still doing low-dose chemo at a certain cadence to just make sure we're continually pressing on things until there's a length of time that everybody feels comfortable with it. So I think stomach, pancreas, things like that are probably in that vein. Would you agree? Yeah. I wanted to ask if low-dose chemotherapy would be appropriate for AML, leukemia.
We typically don't do a lot of low-dose chemotherapy for leukemia, lymphoma. We tend to see the conventionally dense dose drugs work better. And then there are certain types of drugs that we don't use here. And so if you're qualifying or a candidate for those, then we wouldn't be able to give them to you anyways.
Right.
So that one is one where we see more integrative approach with chemo outside. That's what we would do here.
Because those meds tend to work well, correct? Yeah. So hopefully that helps with that one. What is the difference between sarcomas and sarcomas?
Carcinomas and sarcomas. So really it depends. What it's coming down to is what was the original kind of cell that the cancer came from. An epithelial cell, for example, becomes a carcinoma. So like a typical breast cancer, or a typical colorectal, or a typical prostate cancer. It's the most common kind. Sarcoma comes from a mesenchymal cell, more like a fat tissue or a muscle tissue that then becomes cancer. It tends to occur in younger people, tends to be faster growing, tends to be a little more aggressive. And so in those ways, it's more intense.
Did I say carcinoma?
You said...
What did I say?
You said sarconoma.
Oh my God. That's terrible. All right. So sorry. I was just reading. I'm like, what did I say? Sorry. It's okay. Go
ahead. So I don't like even projecting like which one's worse or harder, because I don't know how much, unless it's motivating to you, I don't know how much putting that kind of limitation on your mindset is going to help. In some ways, a faster growing cancer is more responsive to chemotherapy, because chemotherapy kills cells that are dividing, and faster growing cancers have more of their cells are dividing at any given time. So it can, if it's going to respond to chemotherapy, it can respond faster than other kinds of cancers. So not to put false hope, but there's usually a different way of looking at a variable that helps you mentally deal with this diagnosis. The protocols can be similar, but some drugs work better for sarcomas and some drugs work better for carcinomas. And so the protocol overall is fairly similar, at least, especially when we're talking about the integrative supportive stuff.
The kill phase is really the variable and what they're using in the kill phase, right? And then the rest of it is very similar. The other pillars certainly apply, but really the specificity will get in with the kill phase chemo, what chemos, if there are other things that can be done or used within that atomic bomb approach.
Yeah, but the first question, what's the difference between carcinoma and sarcoma? It's just what was the original cell that became a cancer.
Yep. Agreed. All right. Is infrared sauna and infrared red light therapy safe for those with active cancer? Would it make the tumors grow more or only improve healthy cells? It's a good question. I'll let you chime in here.
Okay. So when it comes to these frequencies, red light being on the visible light spectrum and infrared being, just beyond that, one of the ways that those work to help your healthy cells is by stimulating ATP production, energy production. Your mitochondria can actually receive that light and it increases your ATP production. When you have more ATP, your cell has more fuel to repair and regenerate and heal. So
think of it as energy. But yeah, go ahead.
So in theory, if the infrared and red light are penetrating a tumor that's not otherwise being treated, in theory, that could stimulate things. But there are a lot of variables at play, such as where is the tumor in the body and where is that frequency being applied. If you're using it on your face, but the tumor's in the pelvis, I don't think that's going to have an impact. Red light also only penetrates a handful of centimeters. If that, depending on how strong the light is. So if it's a weaker bulb or like an LED, that's not going to penetrate as deep as a red light laser would. And then same with infrared. However, infrared can go deeper, like 9 centimeters, depending on how strong the laser is, if you're using a laser.
But sauna, like an infrared sauna.
Yeah, I don't know that that's going to penetrate deep enough to have a big impact. And one could argue that the upside of your healthy cells having the energy, might outweigh any of that risk. So depending on where the tumor is and how often you're using that modality, and how strong that wavelength is, may or may not be helpful.
Yeah, there's some variables. I think mostly with these, I think we're probably pretty good, but there's some variables there. That I wanted to hear what you had. That's a good explanation though, because I agree. I think the depth matters. I think these can be very good generally, but if there's, like you said, red light and there's something going on where the red light could increase the mitochondrial production of say skin or something like that, and who knows, right? There's that theory makes sense. But the depth, I think, for most people, the infrared and the red light is probably safe, right? Would you agree? Other than the variables that you...
Yeah, and then to be on the safe side, if you add a photosensitizer to it, you're really minimizing what that risk is. So red light at a certain nanometer wavelength can combine with methylene blue, for example, and if the methylene blue has accumulated in the tumor tissue, the red light actually has a cancer-killing effect. Infrared, it's harder to find photoreceptive substances that pair with infrared. We're talking like nano ICG, and even then the infrared wavelength has to be very specific, so there's some nuances there, but in general, like you said,
in general. All right, what diet is recommended and why? Plant-based, keto for people with active cancer? This is probably the most loaded question in the bunch.
I feel like we could spend a whole cancer conversation on it, or a couple.
We definitely could. And I would say personally, it's very individualistic, right? I think there may not be a totally right answer or a totally wrong answer. And I'll give you my thought on this. Keto, we know how that works. We know why that works. But some people come in and they're so thin and they need sustenance, right? So it's hard, even though I use the term, we don't want to throw the baby out with the bathwater sometimes. So until they get good at keto and can keep up the calories and things like that, they tend to lose weight if they're not really good at it, right? So some people, I personally don't think they should be losing weight, even though we want to slam the brakes on the glucose. Keto might not be the right thing at the right time. Is that fair to say?
Yeah.
Go ahead.
I tend to approach it as a hierarchy, because it's one thing to go into full on keto, but did you do the basics first?
Yeah.
And some of the foundational basics are overnight fasting. Doesn't necessarily have to be like full on intermittent 14, 16 hour fasting. You get benefit after 12 or 13 hours overnight. Have you eliminated processed foods, alcohol, sugar, that makes a huge difference right off the bat.
Yeah. Agreed.
Are you getting enough fiber and protein to sustain an immune system and bowel movements? Those need to be in place. And then based on how those are going and what your blood sugar levels are, sometimes what your blood type is, sometimes what kind of allergies you have, comorbidities you have, we might get into let's be more plant-based or let's be keto or even other types of diets. But the foundations have to be there first.
And you have to, great point. You really have to know, honestly, how to do keto really, really well so it's healthy and effective, right? That's one.
You can even do more plant-based keto.
No, exactly.
That exists too.
Exactly. And plant-based paleo and all these. But the plant-based as well, I think what I've said this on here, and I've said this for years even in my practice, is that, now hear me out in the totality. Some of the more unhealthy people that I see come into my practice are vegans, right? Are on the plant-based. But it's not because plant-based isn't good. It's because they're not doing it right.
Or what I've seen is that someone might initially do fantastic with a change that's more aggressive like vegan or keto. But then after 18 to 24 months, we start seeing things go in the opposite direction. And I guess that's what you're saying too. How well did we do it? But also your body, it uses a lot of different nutrients to sustain certain kinds of metabolism. And so you can kind of become deficient in those things, and sometimes it's beneficial to change them up.
Yeah, right. Yeah, and I want it to be clear because I might get some hate mail on this. Plant-based is definitely, I'm a fan. But again, if you're looking at the protein part of it and the plant combining that it takes to get the complete, set of amino acids, that's what you start to see a deficiency in my opinion, the protein. So you start to see hair and nails and skin. And then you can just tell there's an unhealthy look because they're not getting the essential amino acids, the combination. Where when you're looking at a regular, just a real food diet with using pasture raised and pasture finished meats and fish and things like that, they're giving you the complete. So that's why it's a little easier sometimes. So again, not to say that one's right or one's wrong, right? I want to make that very, very clear because there are patients now, if we look at, you see IGF-1 and some of these other markers.
The mTOR pathways.
Yeah, some of these numbers that are really elevated. Plant-based seems like a very, very good option. We just want to make sure that they're doing the right thing within the plant-based or keto diet. That's all. Right? I think that's fair.
Yes.
Yeah. All right. I think we maybe satisfied everybody on that one, I hope, because that's a biggie. All right. Medulloblastoma tumors, type of tumor that can respond to holistic healing, tumor that needs to have either low dose targeted chemo, standard treatment chemo, radiation. Lot to this one, but
I personally don't have experience. I don't believe with medulloblastoma from my memory. It typically presents in pediatric populations, so that could be a variable because we almost exclusively see people, especially on the cancer side, over 18.
Yeah.
Any brain tumor is going to need some degree of
stuff
of
help.
Atomic bomb help. But there's definitely, in theory, a way that all the supportive integrative care can help.
Yeah, and Seifried, had this when he was on, had this in his list. And that is definitely a big, anything with the brain, glucose and glutamine are significant tools to anybody with, whether it's medullo or glio or whatever it might be, to just help suppress the feeding of that tumor cell or those cells. And so I think that's when the ketogenic diet and maybe pulsing that glutamine.
Well, and like you said, you just said the excito or neurotoxicity or excitability, maybe more the plant-based keto because
that's exactly right.
It's the glutamine from the animal proteins that is the precursor to glutamate, which is the excitotoxic or neurotoxic neurotransmitter.
Yeah. So to your point, yes, you probably, in anything like this, in my opinion, with the brain, you're probably looking at a full complement of integrative care, conventional and integrative, and trying to layer it as much as possible. with very specifics of that 4-pillar plan.
Mm-hmm.
So yes, but there's, if it's done in the totality, there's a lot of evidence moving forward, whether it's medullary or glio, that there's some good things that can be done now.
Mm-hmm.
All right.
Do you treat MGUS or precursor to multiple myeloma? Thoughts on MTHFR as a root cause? Yes, we've treated people with MGUS here before, and people with multiple myeloma. The multiple myeloma is in the category of usually needing the conventional care.
Yeah.
But certainly with the smoldering or precursor to multiple myeloma, we could be, really aggressively going after root causes, putting pressure on cancer, precancer cells with high-dose vitamin C.
Mm-hmm.
I'm thinking artesunate too, as long as someone's not too anemic.
Yep.
Hyperbaric, those kinds of things. As far as root causes goes, I know MTHFR is a topic that you and I are both passionate about.
Mm-hmm.
You want to explain that component a little bit?
Yeah, for sure. So MTHFR, you probably hear it. It's out and about a lot now, but basically epigenetics is the expression of these genes, right? Using the enzyme as opposed to just DNA. So the point with that is MTHFR is responsible for a lot of different processes in the body and pathways in the body.
Related to methylation, which is part of detox, your hormones, neurotransmitters, how your DNA replicates to make new cells.
Mm-hmm. It's a biggie. Mm-hmm. And nowadays, and it's probably one of the more common, right? Nowadays, with a lot of the causes that we talk about and see, environmental factors, stress, etc., I personally feel like it's turning these genes on more and more, or causing them to express more and more. So they're now we're seeing it more and more. So the point we'll make with that is, I don't know if it's singular, but epigenetics is definitely something that we want to look at with pretty much anybody, even wellness-wise. It's a big factor today. So if you're on the wellness side, cancer side, preventative side, looking at MTHFR, but there's also a bunch of other genes within that pathway. MTTR is one of them. There's just a few others as well. But then also looking at, the COMTs and the DAOs, there's just so many that could be affecting just the function of the body that we want to look at in conjunction with a lot of the other strategies that we talked about.
And that's how it's indirectly related to cancer, is if it's influencing your capacity to detox and have balanced hormones and balanced neurotransmitters, and it's not working properly, then you have increased toxicity, sensitivity to chemicals, imbalanced hormones, and those are the fuels.
Yeah. And they're stuck in the body. So even when we do this oligo scan, the first thing I look at, if I'm seeing a burden of heavy metals and low B9s and B12s, which are very good with helping regulate MTHFR, the first thing I'm thinking is, wow, they're methylating right, and you start getting into that conversation with them, and then the testing that we're now doing that very, very consistently. So yeah, it could be.
I had a question.
Yeah.
Or a conversation with a patient today about this, actually, because she's someone that's lived her life as healthy as she possibly could, has low risk factors, but ended up getting a breast cancer, a triple positive breast cancer, and this is a conversation she tried to have with her doctor 10 years ago and said, can I have that tested, because I'm very sensitive to alcohol and fragrances and
anxiety.
Pesticides. Anxiety. And so I did this test on her because we're considering she's needing chemotherapy. Everything was removed with surgery, fortunately, but we did agree that chemotherapy is maybe an important factor at reducing risk of future recurrence elsewhere in the body based on her pathology. And as we're considering chemotherapies, we're thinking, how do I make sure that we're gonna handle the chemotherapy well
and clear it properly, so it doesn't overwhelm her. And to your point, those are the people that when they say, oh, chemo this person does real well and this person doesn't, that's one of the main variables.
That's a variable. Yeah. And it was as if I had a crystal ball, because I was checking a lot of different genes in relation to MTHFR, and one of them showed up positive for her called CBS, which has to do with sulfation, one of your liver pathways. And I said, having this one might make you more sensitive to sulfites, so like wine, you're more at risk for acid reflux and bloating, brain fog, and I just was listing off the common associations, and she goes, you just described me.
Yeah, right.
And so it can be really validating for people to find out this kind of information, and then it gives us the tools we need to know, wow, if that person has a gene mutation and they're symptomatic from it, that means that there's definitely dysfunction, because the flip side to this is you can have no mutations, but if that enzyme doesn't have the right cofactors, it doesn't have it's going to behave as if it's mutated.
Right. And that's where you get into testing the cofactors, all the different vitamins and minerals and things like that. So yeah, it's a great, I think that question opened up. That's probably a little bit more than you may have wanted, but that definitely, it's a big deal nowadays. So it's
on our hit list of root causes to go after.
No doubt.
I call it my hit list.
Yeah, no question.
Okay.
100%. When is chemo, so I've been diagnosed with cancer, when is chemo appropriate?
Okay, so as I mentioned earlier, chemotherapy drugs work typically by finding cells in the body that are dividing and killing them. Cancer cells are the most rapidly dividing cells, so when you give a chemotherapy dose, most of it is affecting cancer cells. It's usually used if there's a large burden of disease to try to make it go all the way away. Or if there's something that could be surgically treated, but it's a little bit bigger than you want to tackle with surgery alone. So maybe to shrink and consolidate cancer before cutting out the root of it. Or in a post-surgery setting, like the case I was just describing, where everything's been removed, but there's certain risk factors at play that means that this person, you might have increased risk of it coming back.
Yeah.
Or if there was maybe a bad margin on the surgery, or it seems particularly aggressive, like a high Ki-67,
exactly,
or a proliferation rate, or like I'm thinking like a triple negative breast cancer type situation where you can't block the hormones and you can't use Herceptin, and so how do you put pressure on it from surgery, aside from surgery alone? So there's a lot of different ways that it can be used. Sometimes it's used before a stem cell transplant, or that's how stem cell transplants are done, to remove cancerous bone marrow cells. Then you provide the healthy stem cells as a replacement. So it's part of, bigger treatments sometimes. Sometimes it's used, okay, now I'm going on a tangent here.
No.
But it can be used peritoneally too, if you've got spread to the peritoneum. Usually colon cancers or ovarian, uterine cancers have a tendency, if they're going to spread, to go to the peritoneum, which is the lining that wraps around all of your abdominal organs. You can actually apply a hot chemotherapy wash to the abdomen to clean up cells like that. So there's a lot of variables. Yeah,
it's really, that's where when somebody asked about like a Zoom consult, that's where in person, when you're examining the person head to toe, you're looking at all the data that's there and trying to figure out, okay, say the conventional doctors want to do chemo. Some people come here and we look at everything and we go, based on all these variables that Dr. Ptak just described, you almost narrow it's like a deductive, reasoning where you go, this is, you almost, I don't want to say have to, but these are your options and there's only a few and this is one of them,
It's making me think of the melanoma case that we were all discussing recently. I don't remember if it was here at another location that does low-dose chemotherapy, but a melanoma patient, typically melanoma doesn't respond to chemotherapy, so it's not typically used. But case we heard about recently where they tried the other treatments and it wasn't working, and so whoever the provider was, it wasn't me, did testing to see, well, does this cancer type have chemosensitivity using a DATAR RGCC type test, and it did, and so they did the chemotherapy and it worked. So wow. Sometimes as like or I had another case last year, a woman who was diagnosed with stage 4 breast cancer, and she was put on the conventional drugs. I don't remember exactly which ones, but we're talking like Kisqali and fulvestrant and those realm of drugs. She didn't respond well, and they tried a couple different round of drugs, and they told her basically, you should look into clinical trials. And she came out here and she did the low dose chemo, and she had amazing response. So sometimes it can be used even when you don't think it could work.
Yeah, that was good. That was complete. So I think that gave you probably even more than you needed, but that's good. All right, so let's see, and this will be the last one because we're almost at 6:30. What methods would you take to prevent further growth or change in cancer type? Example, papillary anaplastic. Does your clinic advocate for surgery or active surveillance in these cases? Is it best to choose surgery if there's a potential lymph node spread and then complement with alternative therapies post-surgery? What therapies would be suggested and pre-surgery or post? Lot of questions in there.
Yeah, I think like we can talk about the themes of it in general.
Yeah.
One question had to do with how do you prevent a cancer type from converting into a more aggressive type? And in theory, it's tricky because the treatments that you use, like chemotherapy, are what sometimes makes that happen.
Yeah, right.
And it's cancer type specific, but that's why it's important to, if you're going to initiate these therapies, which are often necessary, we want to achieve a full response.
Yeah, right.
I had a patient recently who over the summer diagnosed with a colorectal cancer, and she's still wrapping her head around her treatment options. Unfortunately, everything's looking stable, but at the same time, we want to act now.
Yeah, right.
And she's out of state, and she's wondering if she can, do a little bit of chemotherapy, go back to finish the school year, and then come back. And that was my answer to her. You don't want to start putting pressure on it,
right,
which can make it more aggressive. Or if you're lightly treating something and not getting all the way, then you're also giving the cancer cells a chance to interact with that chemo and lose responsiveness to it in the future.
Right.
It's also making me think of prostate cancers and hormone blocking. I was reading a review article on this recently about how the type of drug you take to suppress your testosterone to starve prostate cancer tends to influence if the cancer is going to mutate, how it changes. And so with the more aggressive testosterone blockers, we start seeing more aggressive cancer types in the future if it's going to go through a change like that versus the weaker testosterone blockers. So it's a very nuanced conversation.
Yeah, right.
And then does your clinic advocate for surgery or surveillance? I'm wondering if this is a thyroid.
Yeah, anything. Papillary
case. Because thyroid doesn't as often spread outside of the neck region.
And then you look at all these other variables as well, right? Some of the, like we said, some of the testing that we do can help with the decision-making process. If you're seeing circulating tumor cells and you're seeing this and you're seeing that, you're seeing things, and all of a sudden you're like, ooh, we've got some things going on here, then that would probably, from a decision-making standpoint, steer you in a direction that might be more aggressive, right? So I think that was a hard one, just based on the info, because it could go in different directions.
And we kind of answered already, like the pre and post-surgery prep, what that would look like.
Yep. Yeah, so what therapies, and that's the therapies pre and post, that would all be pillar 4, and it would be things that are going to help, the improve the immune system and oxygenate and so forth. So, hopefully that helped a little bit. So, all right, that was good. So, we still have a lot of Q&As in the Q&A. So we will take these, and then we'll make sure on the next Q&A. These are some of the ones that we answer right off the bat. So, so don't worry, we'll get to them for sure. And so we'll sign off and say, look, have a great week. Thank you for being here. Like I told you in the beginning, I think this is a movement that we're all trying to facilitate, and you're a big part of that. So thank you very much. We'll bid you adieu and wish you a great week. Mm-hmm. Cool. Thanks, Dr. Ptak. All right.